issues that are of concern to you and me. And today we want to look at the present health situation in Nigeria. I'm sure you know where I'm getting at. Now, let's begin this way. The health system in Nigeria has, seen a lot of reforms over the years aimed at addressing public health challenges we're forced to face with in the country, from child mortality, maternal mortality, communicable and non-communicable diseases, and just of recent, red alert, Lassa fever. And just when the country is trying to curtail the spread of this disease, we're also battling, on another hand, the prevention of importation of coronavirus into the country. Now, with the growing population of Nigeria, there are indications that there are fewer health workers per unit population than the required, which means that, to provide effective health service delivery to each and every individual in the country. Now, the Ministry of Health is no doubt doing its best to curtail all these challenges, but it has also been described as one of the most complex, with well over 100 mini parastatals, given that every tertiary health institution has its own board and management. So, with the Herculean task laid before the ministry, how will it, ensure that it tackle all these health challenges we've been grappling with presently as a nation? So, like I stated earlier, the health situation in Nigeria as it concerns you and I, challenges and way forward. We have no other person on the platform today than the Minister of Health, Dr. Osage Emmanuel Ehanire. And here's a bit of his profile I'll read out for you. He was born in November 1946. He is from Oredo, local government area of Edo State. He attended Government College, Ibadan, for his West African School certificate as well as higher school certificate. Dr. Ehanire is a surgeon and holds a medical degree from the College of Medicine, Ludwig Maximilians, University of Munich, Germany. In 1976, Dr. Ehanire attended the Royal College of Surgeons in Ireland, Dublin, where he obtained a postgraduate diploma in anesthetics as well as a certificate in general surgery and orthopedic trauma surgery. He also holds postgraduate diplomas from the Teaching Hospital of the University of Düsseldorf and Essen, Germany, in the areas of anesthesiology, general surgery, and orthopedic trauma surgery. He has served on various boards both within and outside Nigeria, including chair of the Board of Trustees of the T.Y. Danjuma Foundation. Now, before going into administration, he had an illustrious clinical career. He was senior registrar, clinical instructor, University of Benin Teaching Hospital, member of the Old Bendel and Edo State Hospital Management Board, consultant surgeon, Shell Petroleum Development Company of Nigeria, clinical course instructor, fracture internal fixation course at the BG Accident Hospital. He also, that was in Germany, he co-authored the orthopedic book, The Severely Injured Limb, edited by John Ackroyd. Now, it will interest you to know that Dr. Ehanire worked extensively in Germany as resident anesthesiologist, resident vascular surgeon, and resident general surgeon in thoracic surgery at various hospitals. He came back to work in Nigeria in 1982 and became a fellow of the West African College of Surgeons in 1984. He is not new to the running of current administrations in the country and happenings at the Ministry of Health, because Dr. Ehanire has served as the Minister of State for Health in the first term of President Muhammadu Buhari, that is from 2015 to 2019, before he was appointed. He is also a seasoned politician. That one was quite surprising to me, as he was the leader of CPC in Edo State and a member of the Buhari campaign organization after the emergence of APC. And he is one man who is very passionate about advancing universal health coverage and emergency medical services. We're pleased to have you on platform, Minister.
Thank you.
And joining me, we have our panelists. So together we will be looking at the issue, health situation in Nigeria, challenges and way forward. Please make welcome Rabi Abdallah, Head of Health Desk NTA Network. We're pleased to have you here.
Thank you, Ruth. Hello, viewers.
And we also have Hassan Zegi. He is President, Association of Nigeria Health Journalists and Health Editor, the Authority newspapers. Thank you very much for joining us.
Thank you, Ruth. Good afternoon, viewers.
Good afternoon. Now, Dr. Ehanire, we all we're all aware of what is happening in the country right now, Lassa fever. And so far, on the 28th of January, 19 states have been reported with the cases. And we don't know. There are fears, it might spread on. But I want you to give us first-hand, update. What is the update right now?
Well, the update, as you have said, comes from the 28th of January. We have had 258 confirmed cases of Lassa and 41 fatalities in 19 states. Now, Lassa is a seasonal endemic disease that crops up usually in the dry season. It is transmitted by the rat, the so-called multi-barmate rat, and it is believed that these rats in the dry season looking for food invade homes or look for sources of food and deposit their feces and urine on human food, and the consumption of this contaminated food begins the process of a Lassa fever infection.
Okay, now for the states that are still grappling with it, I know that, Edo, Ondo, and Ebonyi states still have the highest record so far. What precautionary measures, should states, be putting in place at this time? Because 19 states, we have 36 states. The numbers are increasing.
Yes, Edo, Ondo, and Ebonyi have about 89% of the cases, and it was the same way last year. Nobody knows exactly why it is so, but for some reason these are the frontline states when it comes to Lassa. But you also have cases springing up in Taraba, in Bauchi, and Nasarawa state now and then. Now, the advisory is that all doctors should be aware because they can pop up anywhere. They popped up in Adamawa and the places where they normally are not noticed. So the guard is relaxed in those places, and they don't think of Lassa when they get somebody with fever. The first thing doctors think of is malaria, because malaria is also endemic. And
because they share the same symptoms? Or?
They do, yes. Okay. At the initial phase, they have very similar symptoms, and they treat with usual antimalarials. And if there's no response, they want to try another set of antimalarials. So it takes a while before it clicks that this might be something different if they are not used to it. So in those states where the recurrence is high, doctors are already much used to it, so they know very quickly how to look for additional telltale signs or how to respond if a patient does not immediately respond to antimalarials. So the good side of it is that the case fatality rate, that's the number of people who lose their lives from Lassa fever infection, used to be just a few years ago 30%. Now it is 15%, which means that the treatment is getting better, the reporting is getting earlier, and we're getting a handle on it. Of course, we want to drive it to zero.
Honorable Minister, while speaking earlier on, there was something that you said that caught my attention. You said, we don't know why. And when you said, we don't know why, it means there's something missing somewhere. It's a question. And that's why I'm going to ask you, for the fact that Lassa fever was first reported in 1969, that's some 51 years ago. And 51 years down the lane, it has become a norm, year in, year out. It's not even longer seasonal anymore. It just comes. It comes and goes, comes and goes. We don't know why. How much are we putting into research to unravel why certain things are happening? What is fueling Lassa fever? Why are we not prioritizing research and development?
Well, we are prioritizing research. A lot
How have we done that in the case of Lassa fever?
Oh, yes, a lot has been learned. In the first place, there's a particular medicine that has been developed, which has helped to save a lot of lives. Ribavirin, which we have in large quantity, which we distribute, and which has helped a lot in saving lives. Moreover, However, we know the vector. We know how it goes, how it's transmitted, and we're able to also advise the people, the population on risk communication. We know that people spread their food out on the streets or on the road to dry, particularly cassava or other forms of grain. And once they turn their back, rats go in there and help themselves, or lizards or other kinds of crawling animals, and leave their footprints behind. We know that rats also go into homes and eat food that is left somewhere, either dry fish or climb into gari bags and so on. So we know that through that avenue, the mission of the rat to spread the disease takes place. That much has been known. But as far as the virus itself is concerned, yes, there's a research going on vaccine.
Yeah, definitely. I was saying yes.
Vaccine research is going on. It hasn't reached the stage yet, so they're going to do clinical trials. But science is a slow-moving bus, and it eventually gets where it's going, but slowly.
Which of the institutes is handling the research? We will not.
Well, there are many institutes. I can't name them off the cuff right now, but we have involved some of our very top virologists. Virologists are scientists who deal with viruses, and this is clear that this virus belongs in the group of what we call the viral hemorrhagic fever viruses, and the top virologists in this country are on it. There's a committee that is studying trying to find out if there's anything new to learn about the virus and its behavior, and the knowledge used is applied in science and also in developing antidotes and vaccines.
Okay, Honourable Minister, coronavirus is threatening the whole world, and the question is, in case it slipped into Nigeria, how prepared are we to face it?
The first thing is to do everything we can to make sure it does not slip into Nigeria. And we are doing a lot of strategizing. Tomorrow we are going to have an interministerial meeting that will involve the Minister of Aviation, Minister of Transportation, Minister of FCT, and so on, because we have calculated that if it slips in, as you said, it might likely be through an airport. It's not likely going to be someone walking across the border, because it's happening all the way in China. It's also not likely going to be someone at the seaport, although that's not ruled out, because by the time a ship comes in with sailors from China, it takes weeks, and the infected person will have been so sick by then. They will be identified. But if it did happen, we are also looking at the seaport just to say that we have not forgotten about that route of entry. But the majority of cases will likely be the risk of coming in by air. So the international airports are under heavy surveillance by the Port Health Services and by the Nigeria Center for Disease Control. They are doing scanning with thermal cameras, and patients are being keenly observed to see anyone who has any signs of any illness. They are taken aside and they're questioned with travel histories obtained. If they have been outside in the Orient areas of China and around there in the last 2 months or so, we would like to know, so that we'll continue with the suspicion and the way we go about diagnosing it.
And from what you're saying, there's a synergy going around with the Ports Authority.
Yes, indeed. That's why we are inviting the Minister of Transport with the Ports Authority, the Minister of Aviation because of Federal Airport Authority, and the FCT because they host the airport. Yes. The FCT means that they host this airport here. And same way in Lagos, the Lagos State Governor will be involved, or Commissioner for Health, and same in Enugu, Kano, and all the international ports of entry that we have.
So let me take you back to the capacity of health workers. I'm talking about healthcare professionals now. In terms of standard infection prevention and control measures, what is the capacity of these health workers?
The capacity is good. There is a lot of training. As you know, these ailments we are talking about fall in the area of public health security. And talking about public health security, the National Security Advisor is also on the team that we are going to be constituting. And public health security is also an attraction of the World Health Organization. So we work with the World Health Organization to know what is the latest on these viruses, what is known about it, or what measures are being advised. So the capacity is good. The Nigeria Center for Disease Control, as you know, is new, is young, but they are doing a very good job. And they're receiving support from the more experienced organizations like the United States CDC, from the World Health Organization, and they have obtained a lot of equipment. We have at least capacity to at least 5 laboratories can diagnose Lassa fever now within 4 hours. So that's a tremendous improvement. And sample transportation is well organized, although it still needs some fine-tuning. There is an agreement by a transport company to bring samples in from state capitals straight away to Abuja for testing.
Okay.
And the laboratories work day and night, around the clock.
Just a rider to the question Ruth asked earlier on regarding this standard safety precautionary measures. Is it about negligence? Because I'm worried about the fact that we have issues of deficit in the human resource for health. We have the issue of brain drain. And we have, in the event of disease outbreak, health workers dying. Why is it happening that way? Is it negligence on their part? Or the basic standard precautionary measures and not what they should be? Are they properly kitted?
Okay, well, let me start from the very first one, the deficits. Yes. We have a good complement of staff now. But when we have a threat that comes up, as it has come up now, there's increased need for manpower. So an application has been made now to increase manpower, to bring in doctors, to bring in nurses, to bring in people who have been trained. So you need more manpower for the period in which you face a threat. There's also a requirement for more resources to purchase antidotes, to purchase personal protective equipment, to purchase other preventive equipment that you need to protect both the workers and also others who are necessarily having to go through some risk of working with infected patients. For example, the ambulance driver, he'll be at some little risk. So there is a demand for more resources, which has been presented to higher quarters, and so the resources are usually promptly made available. This government is very, very good in doing that. So we're not going to have any shortage of resources.
I'm going back to coronavirus. I might be wrong, but reports reaching us out there has it that it is being underreported that the situation is actually more critical than China is telling the world. On that note, I know that even some international airlines have placed travel bans. Some countries have. Is Nigeria likely to go that way? When you look at the traffic between China and Nigeria, talking about businesses and other bilateral relations.
Because earlier, just to add to that, earlier on the news, international news, the international community is urging, countries to, put on, more strategic measures, because about 20 countries are already affected, latest.
Yes, that's correct. The alarm has gone out from the World Health Organization that countries should be vigilant.
Yes.
But they have not yet declared it a disease of public health concern, not yet. And part of the reason is that they are still trying to understand this outbreak. The case fatality rate is relatively low compared, for example, to SARS or MERS. That's to say, of the number of people who are infected, how many lose their lives by percent. So for that reason, that's one of the factors they look at, how really dangerous is a disease. People who fall sick, how likely are they to recover, and how likely are they to lose their lives. So this is the World Health Organization obviously looking at all these things. All that is clear is that this disease spreads rapidly. And
South Korea just confirmed its first human-to-human transmission.
Yes, human-to-human transmission has also been confirmed. Before a few days ago, that was not even known how it's transmitted. So new knowledge is coming out.
Should we be on a panic alert?
No, we should not at all.
Okay.
For First, because we are relatively far away geographically from the epicenter. Secondly, the travel volume, the passenger volume between Nigeria and China is not that heavy compared to the United States, for example, or Japan. And those countries, for that reason, have been able to get some importation of this disease, or countries in the neighborhood have been able to record cases. We don't, relatively speaking, don't have that much of a heavy volume of travelers between Nigeria and the
Honorable
Orient.
Minister, sir, we might not have that heavy volume of travelers. Our health-seeking behavior is what worries me. If you recall, the American that got infected when he went to China could not be detected at the airport until he got to America, he got to the US. It was some symptoms of flu. He even thought it was a common flu that made him to start wondering. Out of curiosity, he decided to present himself to a health facility, and lo and behold, he tested positive to coronavirus. Do you think if that had been a Nigerian coming in, that the story would have been different?
It would have been the same thing. That's why we are using all avenues to
Would it have been the same thing? When you look at our health-seeking behavior,
to think so. Yes, I want
when
to think
someone
so.
would rather go buy a Procold or paracetamol, take
Self-examination.
Well, I want to assume
self-medication and all
I
of
want
that.
to assume that anybody who's bought a ticket to go abroad and come back has resources, listens to news, and listens to TV, listens to radio, and will hear what we are talking now. And I want to believe also that if they know what is being said about this disease, they will look for help.
Yeah.
They won't go and sit at home and say, okay, this doesn't matter. Because if you know you are coming from China, you came in healthy, and then suddenly you are feeling ill, you are sneezing, coughing, you are unable to breathe, you know your life is at risk. So definitely they will come out and report and do self-reporting. Self-reporting is what we are encouraging, and also the reason we take any of these opportunities now to also enlighten the public, to do a risk communication and let people know what is out there and what to do in case of difficulties of health.
And there was this alarm that was raised just yesterday about importation of foods possibly being transmitted, that could be likely transmitted. Talking about the virus, the coronavirus. I don't know how true is that. I don't understand. There are people who may not understand how this virus works, how it can be transmitted. Can you clarify on that? Is it possible to get it from foods being imported?
Well, everything that there is to know about the virus is not yet known. That's clear. That's why researchers are working on it. All we know now is that it is transmitted by droplets, and that droplet infection is when you cough or sneeze in the presence of other people and you release droplets which others can inhale. It gets into the nostril, and there's an infection. And the more people there are in a room, the more crowded a place is, for example, inside a very crowded bus, the higher the risk of many people getting infected by one person. And but what is peculiar about this virus is that it multiplies rapidly. Within 3, 4, 5 days, it's giving symptoms already. So the behavior of the virus is not yet quite clear. Now, if somebody were to cough, for example, onto food or to apples, the question will arise, and if somebody else ate that apple, the question will arise if that person will get infected. But science will also have to answer, how long does that virus survive out in the open?
Yes.
If it survived only a few hours, then there will be no risk. And if the virus could survive a long time, then there will be risk. Science has not yet answered that part of the
research. That's where research.
Yes, of course, it's going on. But remember, this is a new virus. It's called a novel virus.
Yeah, so research.
I'm looking at two areas. One, since the virus is still shrouded in, like, we don't know it yet, don't know much about it yet, do we have the experts that can be able to handle it in Nigeria? And secondly, I'm looking at the rural areas. We have been talking about PAC revitalization all this while, and in our primary health care, do we have enough strength to be able to handle such if it goes to the primary in the rural areas?
Well, in the first place, it has been said that the coronavirus is new. It's a new virus, and it is very similar to other viruses. It's very similar to the influenza virus, similar to the SARS virus, and probably not so virulent as those other ones. Just yesterday I was hearing that even the influenza virus, the common cold influenza virus, kills up to over 600,000 people a year. But because it does that slowly and people are used to it, it does not really hit the news. Okay. But the point is that we don't expect that this virus will get to rural areas except people who have traveled out went to rural area. So we have yesterday issued an advisory that the Ministry of Health, that all people who are coming in from China should self-isolate. Self-isolate means stay in your house, don't make contact with any person, and also protect your family by staying in your room. Even if you came in without symptoms at all, stay in your room, and if after 2 weeks you're okay, you can join community. Stay away from...
How do we ensure that they will comply?
Well, we can't ensure, but we want to assume that everybody is also worried about their life,
yes,
and are worried about their children's life or their family's life. So the advisory is for those who have common sense, which I believe most people will have. There might be the occasional rogue element who will not comply.
That's the essence of public enlightenment and health literacy here.
Correct.
And my question will revolve around the fact that so much is probably being done at the federal. How are we ensuring that this trickles down to the states, to the local government, in the language that they understand?
Yeah, that's correct. As far as these outbreaks are concerned, this is relatively new. Once again, I think we are dealing with a particular class of people who travel out, and we believe that those are the ones most at risk. Those at the other stratum of society probably will not be primarily infected, probably secondarily from relatives. So for risk communication at that level, if the need arises, it is done. It's done in local languages, and you spread the language to them. It's being done already in Lassa, with Lassa, that you spread the language to them, go through the chiefs, go through community leaders and local government authorities to spread the language about behavior change communication, social and behavior change communication, to reduce the risk of getting infected with Lassa.
I asked that question because when Ebola struck, it was the same anxiety. Ebola was imported into the country by a traveler. So it's about the same scenario. So if you're saying people most at risk of certain class, and as such, rural dwellers are are you saying they shouldn't be that much of a source of concern to us?
No, what I'm saying, in the first place, at the time the Ebola index case came in, nobody was thinking about it at all. So it just slipped by. Yeah. But this time now, we are thinking about it. We are looking out for coronavirus. So the scenario is not the same at all. And we are actively looking out for cases that might fit the definition.
All right,
at the entry points, at all points of entry.
So let's bring it back home now. Lassa fever, that's the one we're currently dealing with. Now, I know that just recently the Ministry of Environment has placed the environmental health professionals of the Registration Council to, ensure that every environment is rodent-free. What is the synergy like with the Ministry of Health? And if we must say no to Lassa fever, if we must end it, is it that we must kill all the rats first? Is that even possible?
Well, I don't think it's possible to kill all the rats, but where you can get the rats, well, I think you would not let them go because they are a risk to a population. But there is synergy between the ministries. As a matter of fact, we are planning an interministerial summit on health-related issues. The design has been done. The technical committees will talk to each other because there are a lot of cross-cutting relationships that connect certain ministries. You mentioned the Ministry of Environment, but also the Ministry of Water Resources.
Agriculture.
Okay, Minister of Agriculture, and the Ministry of Information, because they spread news. And also, interestingly, the Ministry of Women Affairs, because they handle the families.
Yes,
Water resources.
They handle family health.
When it
Water
comes to issues.
Exactly. So we are involving the Women Affairs Ministry in this interministerial summit which is being planned, and it's for the benefit of all sides, because particularly the health sector, because if you are able to take care of waterborne diseases, take care of hygiene, sanitation, and then we're able to take care of nutrition, you have solved more than half of your disease burden. It's cheap.
Yeah.
It costs a bit at the beginning. We are very interested in that because we are very interested in disease prevention, and just as we are interested in health promotion. So the disease prevention aspect is cross-cutting with the ministries I mentioned now, and this collaboration among these ministries will take us a long way forward. All you just do is add vaccination to it, and then you are dealing with far fewer diseases than before.
Vaccine is still so far away from us right now. And you had said, when Ruth asked previously, you had said it's not possible to rid our environment of all the rodents, the rats, But if you recall, in India, when India had that huge challenge, that at some point, they had to think out of the box. They made it in such a way that a suitor gets to marry his wife-to-be based on the number of rats he's able to kill. And it worked. So can't we just think out of the box and come up with something that,
definitely not the marriage idea.
Well, you never can tell. It's about thinking out of the box. It's still part of looking for solution, because it's been 51 years of Lassa fever in this country.
Well, in the 51 years, there has been some improvement, I would say. In fact, Lassa was almost completely neglected until a few years ago. Okay. And it's just coming to the front burner now and getting more and more attention. But I'm not saying that you should let the rats go. What I'm saying is that if you, wherever the means you have to get rid of them inside your home, you do that. But you see, rats live both indoors and also outdoors. Yes. To get rid of those ones outdoors is a huge challenge. And there are times when these rats find ways of getting into your house when food is scarce outside, and that's where the risk factor comes in. If there's any way to stop that, to prevent that, to lock your doors or whatever, everybody should take that, and whatever is known about the life cycle of rats can be used to use their numbers and the risk they pose to humans.
Now, Minister, talking about our environment and Lassa fever, some years back while we were growing, there were these head workers that normally go around the villages to ensure that people keep their environments clean. From my findings, it's like they are almost non-existent.
I think even adding to that, there's a deficit in the number of these health professionals, these health workers, because recently I had a chat with one of them, and they're actually grappling with that challenge of having more people come on board. And I asked the question of why is it that it's only when there is a disaster outbreak like this we get to know about them. So is there something your ministry can do while you are?
And to also ensure that we recruit more and spread them around so that we can be able to help with Lassa fever control.
They had actually complained, the environmental health officers have complained that they are not being employed. Because we had the registrar some times back, he said the local governments are not employing them, and we know their roles in sanitation, hygiene, and all of that. The roles they played back then as Wole Wole, Dubagari, I don't know what they are called in Igbo language. Why are they so scarce these days? And our disease burden keeps increasing, and we need them. Why are they not being employed?
I think, that's a question that's open to any kind of a guess. I think, if you ask me, that at a certain period in this country, we began to look at healthcare. I think probably at the time we had a lot of income. We began to look at healthcare as being large hospitals in large cities, and people were competing to, or rather states were competing in building the largest hospital, and they were very proud of how big the hospital was, and began to forget about the small cities and the villages and the primary health care, and they fell into neglect at the time. And it is this regime that's actually refocusing on primary health care, on taking health care from the foundation, and the foundation is at the community level. And that's where most of all these indices we are talking about occur: the maternal mortality, the infant mortality, not at the high-end hospital. And if you don't address that level, the indices will be bad. But we took our eyes off the ball at a certain time in the history of this country, and the large hospitals are not able to solve problems in rural areas. So the policy of the government now, the present government of President Buhari, is to go back to beginning, have at least one primary health care center in every political ward. That will give you nearly 10,000. At the moment, we have about 4,000 functional. We have about 5,000 or 6,000 not to go. And in the meantime, we have also changed the design from primary health care center that works like an office from 8 to 3. We want something that works around the clock, that we work in shifts. We have quarters for staff. We have electricity, because many of them now don't have electricity. We have probably solar-powered electricity and water. And if you do that, you're able to attract more staff and render much, much better service. And the primary healthcare center is a fantastic platform from which to carry out a large number of interventions.
And talking about these interventions, let's look at funding and also public-private partnerships. I know that the ministry entered into PPP with life-saving chemotherapies treatments to reduce cost and access care sometime last year. And there are also other interventions that for the cancer chemotherapy is about 50% reduction. And then we also had the hepatitis and other diseases of about 1.3 billion naira. These are, part of the PPP interventions and all of that. But if the ministry must ensure this primary health care for effective service delivery to the general public you're talking about, are there other, aspects we should be looking at? Especially now that we're trying to battle Lassa fever, funding is also a challenge.
Yes, to go back to the primary healthcare center, I said just now that it is an excellent platform to carry out very many interventions, which include what we are talking about now: the sanitary inspectors, the health inspectors,
environmental health
workers for hygiene, sanitation, domestic hygiene, food hygiene, advice on nutrition, on baby care. That is the excellent platform from which you can do all of that. And also disease finding, case finding. If you're looking for cases of TB, or you were asking just now about the finding coronavirus in the villages, if you had healthcare workers there who were trained at that level, they'll do it much faster than anybody sitting in the state capital or sitting in Abuja. So this platform is what this government wants to build, and we need the infrastructure, we need the human resources, and we need the amenities to set them up, the organization and the funding. Now the funding is the question you raised.
Yes.
The government source of funding is the National Health Insurance Scheme, which is undergoing changes because it's going to be transformed into a scheme that is mandatory for Nigerians to join, and working with the state health insurance scheme to raise enough money to address a large number of diseases for all those who enroll in it.
So are we good to go with the amendment of the Act now?
Well, it's still undergoing some work. And in the National Assembly, we have been told by the parliamentarians that it will be ready soon. But I think there will be a public hearing before it goes to the final level.
Okay, there's no doubt about the fact that the federal government is making concerted efforts, at driving, repositioning primary health care. Could same be said about the states and local governments?
Well, that's where there's a problem.
What do we need to do to get their buy-in, total buy-in?
Indeed, the health, as you know, is not on the exclusive list, it's on the concurrent list, which means that the state governments have a role to play and local governments have a role to play. And the extent to which these roles are played varies enormously, and the resources that they bring in vary also. I'm not sure if it's because they don't have the resources or they have other priorities. I'm not sure, but the primary health care is technically under the local government, and it's not really under the federal, but the primary health care development agency is an organ of the federal government to support primary health care, because primary health care, without it, secondary and tertiary will not work. So the developing primary health care is an extremely important undertaking to also assist and reduce pressure from tertiary health care. Now, the one we have not mentioned is secondary health care, which is actually also the responsibility of state governments. And secondary health care, we envisage as little cottage hospitals, 30, 40, 50 beds, and not more, with enough doctors to receive referrals from primary health care centers. We're looking at least one in every local government area, which we are urging the states to actually work upon, rather than build big hospitals and teaching hospitals. That's federal government's work. But the states, if they will develop the secondary healthcare level, so you have a middle ground between primary and tertiary, to take away a lot of the cases that don't need to go to the university teaching hospital. You could reduce the pressure and they could focus on a lot more difficult issues. So we are looking at strategies and of being able to engage the states to develop secondary health care.
And I know you're very passionate about universal health coverage. And if we've heard cases of when people complain about the NHI scheme not really being effective. I'm just saying what people have confirmed. Now, I don't know if the ministry is also looking at overhauling the scheme, because if the essence of NHIS is to meet the most vulnerable people who cannot afford this cost, and they're not getting the benefits of that scheme, which is supposed to be part of their rights as citizens. Now, should there be an overhaul? That's one. And two, a lot of them cannot, I'm talking about the grassroots now, they cannot afford to pay some of their bills. The scheme covers some certain persons in society. That's where I'm driving at. What about those vulnerable people who are left at the mercy of healthcare providers?
Well, the reason why the perception is there that the National Health Insurance Scheme is not functioning is that it attends only to the formal sector, which is less than 5% of the population. Those who are in government or who have jobs with companies who enroll with NHIS. But that's why its mandate is being expanded to now compulsorily or mandatorily register more people, so it can cater also to the needs of more people. And to do that, it has to trickle down to states, who now have created state health insurance agencies or schemes, or what they call them, who now work together with the NHIS. Now, the concept will eventually produce a large pool of resources from which a treatment can be given to many. And there will be those vulnerable ones you mentioned who will be exempt because insurance is paid for them through another scheme. Okay. From the present permutation, we're looking for 15,000 naira a year per head, which the NHIS is looking at as contribution per year, 15,000. So if you do that, you are covered, and that will give you the pool that we're looking at. I think that 15,000 is affordable to a large number of people for healthcare in a whole year. So
Yeah, I think beyond what government is putting on the table, there's still the issue of getting a sustainable funding mechanism, for the health sector. For instance, for the health insurance, and a lot of people have said, why can't we tax, for instance, GSM service providers? We can tax them. It's an alternative. A lot of people had said we could generate, such funds, tax them. Even tobacco companies. We can tax them. So people always, when they make this suggestion, I'm just wondering why it is difficult to explore such, alternatives.
yes, it's been done in several countries, and Nigeria has been looking at it. It's not that it's not, but it requires a law, and that law will have to be made. Those are what you call the sin taxes for luxury goods, for alcohol,
Yes.
tobacco, and so on. They're called sin taxes. And some countries collect such amounts into the treasury. Some dedicate that amount to the health sector, depending on which one is adopted. It has been discussed in Nigeria, and they probably come up at some time to raise taxes on luxury items and dedicate them to the health sector. It is a work in progress.
Okay,
You're
Minister,
itching to say something.
I know our listeners will be keen to hear you us talk about the issue of the hospitals and the HMOs and the main health insurance headquarters. Now, as journalists, what we found out is that hospitals complain that HMOs don't pay them in time. Now, that's where the issue is. And so they give poor services to health seekers. Now, is there any way we can do away with the middlemen, that's the HMOs?
Well, that is a question that the National Health Insurance Scheme, which is an agency, should be answering. They have developed various scenarios that would address that problem you are talking about, because it is true that there are complaints here and there about the HMOs and payments and those who provide service, and sometimes that led to quite a lot of arguments that we have had to wade into. But again, the health sector, particularly also the health insurance scheme, is a work in progress. There's a new law coming up to expand it, and at that time, with a new strategy will come up. I've had a conversation with the executive secretary on a new approach that we're looking at to solve these problems.
Okay.
We have had discussions. It's still in the early stage of developing a new concept, a new approach that excludes a lot of the problems we are seeing now.
All right, we're almost rounding up. So
Cancer burden.
it has to be your last question.
Okay, fine. Cancer burden in the country remains a huge challenge. And I know that Gavi, that's the Global Alliance for Vaccine Initiative, had issues. They are the custodians of vaccines, talking about partners now. For cancer, it has been established that if you get the HPV vaccine and you get to immunize young girls before they become sexually active, you will have succeeded in tackling or dealing with the issue of cervical cancer. Gavi had issues with Nigeria, and thanks to Mr. President, Nigeria was able to resolve that, and there's a renewed confidence in the country from Gavi, such that even the leadership of Gavi visited this country last year. I'm interested in knowing the possibility or the difficulty in getting Gavi to consider Nigeria as a beneficiary of the human papilloma vaccine for girls.
Yes, it is in the program.
Have you been talking?
Oh yes, we are looking at it. It is one of the antigens we are looking at for human papilloma virus vaccine. It's something that we are looking at, but all these things have financial implications, and you have to prepare the money before you make the order. But it is on track. we have a particular arrangement now with Gavi that tides us over the next, I think, 9 years remaining. They brought $1.03 billion, and Nigeria brought $1.97 billion on the table to cover a range of vaccines for the next, it was 10 years when it was signed, but I think it's about 8 or 9 remaining, which will provide the range of vaccines that we're looking for. And both the rotavirus, which is also extremely dangerous because it is responsible for the diarrhea that kills a large number of children. Okay. It's on the program too, and various antigens that will solve basic health problems, which we look at as preventable. As we say, it costs money, but at the end of the day, prevention is cheaper than the cure, and also better than cure.
And talking about this prevention as we wrap up, I want you to tell Nigerians, if there is hope, we were able to conquer Ebola. We conquered Lassa last year. We're just starting the year with another Lassa. What is the hope for Nigeria?
Well, the hope is good. The future is bright. This government is doing very well. It's on track. It's investing a lot in human capital development. The health sector is key to the president's heart, and particularly the basic health care provision fund, which has been released to the health sector, which we are working on implementing right now. So there's hope, but we need to be able to carry out a lot of reforms in the way we look at things and change the way we view. We can't continue using one method which doesn't work because they say, oh, that's the way it is. The general order of service must undergo modification. Many countries have changed processes. Okay. 2-3 times, while Nigeria has remained on one process. So things have to change. We have to carry out reforms also in the health sector, in the hospital sector. And I'm happy that the health insurance is doing that, primary health care is doing that, NCDC is doing that. So we need to get on with the other agencies.
Thank you very much, Dr. Osage Emmanuel Ehanire, the Minister of Health. Thank you so much for your time. I know, Hassan, you want to ask the final question, but we don't have time. We're out of time. Thank you so much. It's been nice having you on.
Thank you for inviting me.
And yes, Nigerians will definitely sync with everything you have said here on the platform.
Thank you.
Also thank our panelists, Hassan Zegi. He is the President, Association of Nigeria Health Journalists and Health Editor, the Authority newspapers. Thank you very much for your contributions. And also our very own Rabi Abdallah from there. She's the head of the Health Desk, NTA Network. Thank you so much.
Thank you so much. Glad to have you.
All right. So for the past 15 minutes and more, we have been looking at the health situation in Nigeria, the challenges and way forward. Of course, you know, like they always say, your health is in your hands. And the minister has talked about precautionary measures the federal government is putting in place, talked about collaboration with other ministries to ensure that we put a stamp and saying no to Lassa fever and no entry to coronavirus into the country. And other health issues are in progress, that's what he said. So we'll definitely continue to do our best as a nation to ensure the prosperity and growth of this great country, Nigeria. This has been Platform. I am Ruth Aguwele. Thank you so much for your time. We'll get to see you some other time. Bye.